Okay. Everybody here all right? See a lot of familiar faces in the audience. It's terrific. Any students, interns, residents? Figured this side of the room was that, but okay. Um, this is a pretty straightforward lecture, knee arthritis. If you have any questions during, just yell them out, especially if they're clinical questions. You have a patient you can't quite decide what to do with, just go ahead and yell it out or raise your hand. I'll be happy to answer that while we're in the middle of it, okay? Yeah, I don't mind if you just read them to me.
I can pull them up right here.
Oh yeah, just yell out if you see one, and we'll just answer them. I think that's I think sometimes at this level, that's probably more effective than us just reading slides all day. Okay, just our learning objectives. They're not quite as good as Dr. D'Amico's. They never are. But understanding the natural history of osteoarthritis of the knee, recognize some of those signs and symptoms of knee osteoarthritis, understand a little bit about the physical exam, because sometimes that can take you in a direction maybe that isn't osteoarthritis in some cases. What do we order? How do we create that or make that diagnosis of osteoarthritis of the knee? Sometimes it's very simple. You just look at the patient, right? You're like, something's not right there. Other times we may need an algorithm, not just for treatment, but also for diagnosis as well. And again, if you have anything clinically that you want to ask, go right ahead. I'm happy to answer those questions. All right, we know that there are a lot of patients that suffer from arthritis, not just knee arthritis, hands, feet, ankles, knees, hips, right, shoulders, elbows. It's all over the place. But the knee tends to be one of the more common ones that we see in the office. It is a weight-bearing joint, so that doesn't help either. It does affect a percentage of Americans, probably a little bit higher than that, greater than 60 years of age. There's the preponderance for men and women. The estimated cost, that's 2009 numbers. You know it has to exceed everything. You know, since COVID's hit, just add 30% to that, and you're probably pretty accurate. Knee arthritis, it is a degenerative joint disease, right? So usually degenerative conditions, I'm a bit of a wanderer, so let me know if I wander away from the microphone. Usually those conditions are ones that get worse with time, right? So it's not like you have severe arthritis, and if I see you 5 years later, you don't, right? You're still going to have severe arthritis, probably going to be worse than it was 5 years ago. Again, the knee is one of the more common areas that we see osteoarthritis. And then it's really a collaboration of different things that bring us to that diagnosis of osteoarthritis. Destruction of cartilage, yes, right? That's part of it. Osteophyte formation, right? Bone spurs, that's part of it. Maybe even changes to the synovium or the lining of the knee, changes to ligaments, whether they're intact or unstable. And then certainly changes to the cartilage, the meniscus of the knee can be a very specific finding when we're looking at these degenerative patients. We have three compartments in the knee. We have the medial compartment, the lateral compartment, and the patellofemoral compartment. And so when we talk to patients, we'll say, well, you know, this compartment looks pretty bad, or this one looks pretty good. Or when we're maybe speaking to each other as colleagues, we'll say, well, you have unicompartmental disease, right? One compartment affected, bicompartmental or tricompartmental disease. Usually when you're reading your x-ray reports, you'll see tricompartmental disease. And I think that's a very general term because it doesn't actually speak to maybe which one was worst of the three and which one was the best of the three. But you can see degenerative changes all the way through when we look at those knee x-rays. The knee is sort of a complex hinge joint. It bends and straightens, right? Flexion, extension. Otherwise, we wouldn't be able to sit like that. There is some rotation involved. And when we talk about rotation, we're talking about the tibia relative to the femur, okay? Rotation, especially in flexion. And then some gliding, right? So we have some movement anterior to posterior of the tibia relative to the femur. Anytime we talk about motion, especially the knee, we're going to oftentimes talk in respect to the tibia relative to the, we're going to assume the femur is fixed for a lot of these examples. Even when we're doing our test, our Lockman's test, you know, we're stabilizing the femur, we're moving the tibia beneath it, right? Weight distribution, about 60% through the medial compartment, 40% of that weight through the lateral compartment, all things being equal. And those numbers vary too. So if we have a deformity, a varus deformity, or a valgus deformity, those numbers aren't going to be 60/40. We have a varus deformity, maybe it's 65, maybe it's 70. Okay. We have a valgus deformity, maybe we're creeping towards 45 on that lateral side as well. I hated this in medical school, and I still hate it. Zones of articular cartilage. I don't like microscopes at all. So if we sort of went through a piece of cartilage and then we looked at the different layers, we'd see that that superficial layer, right, that forms that gliding surface that the bones sort of have when they're touching each other in the knee, the femur and the tibia. And you can see the orientation of those fibers, right? They're oriented in a pattern that would help them glide past one another. And if you look at the middle layer, it's sort of thicker collagen fibers. And really that middle layer makes up a great majority of the cartilage itself in cross section. Then you look at the deep layers and they look like they're resisting loading. You know, they're not nice and smooth and flat. You know, they're sort of perpendicular to the to that tide mark. And then you have your calcified cartilage right above the subchondral cartilage. So that's how they're oriented. Now, as you get arthritis, they don't tend to orient as well, which becomes one of the problems that we see in cartilage as well. Although we don't take an x-ray and go, oh, your cartilage layers are not oriented appropriately. That's the problem, right? So this is already happening. And then we start to see other things, other changes. But somebody smarter than me was able to take biopsy that, look at those fibers and their orientation. So pathophysiology. So things that you think would be helpful, like more water content, is not helpful. We said collagen losing its orientation, and then a loss of chondrocytes. We know chondrocytes, cartilage cells, are important. Now, cartilage is just not chondrocytes connected to chondrocytes. There's a lot of other sort of tissue in there, but chondrocytes are the ones that are really leading the charge in terms of cartilage formation. That little picture you can see on the bottom right there gives you some idea of what a knee looks like with arthritis. That's more than likely during a total knee. And you can see that the different compartments, we're going to say that left side there is medial, right? Because the patella has been everted laterally. You can sort of see it on the edge here. Do I have oh yeah, right here. So here's your patella, right? This is the suprapatellar pouch up here, trochlear groove, medial femoral condyle, and osteophytes, lateral femoral condyle. You can see that probably is cartilage missing, but that's an osteophyte. So that area is not indented. It's actually raised a little bit. If we ran our finger over it, we feel that bump. Same here. And when we do something like a knee replacement, part of it is to remove some of these osteophytes, not because we're curing the cartilage, but we want to get a femur of manageable size, and we want to be able to balance that knee during the surgery. You know, the meniscus is sort of an important structure, both medially and laterally. It does increase the contact area of the knee, meaning we have a round femur on a flat tibia. That's probably not the best design, right? Because we know where all that pressure is going to go, right? It's going to go in one very small area as that round bone touches that flat bone. And so the congruency of the meniscus helps to sort of take that one loading point and sort of spread that pressure across a larger surface area. It is elastic, and certainly more elastic than articular cartilage. I don't know if you've had rotations yet where you've seen the meniscus, or even some rotations where if you're with us and we're cutting it out, you can feel or squish it with your finger and be able to tell what kind of material that feels like. And then I think you can appreciate those properties of shock absorption after that. When we look at synovial fluid and you do a synovial fluid analysis on these patients, you'll find that, yes, hyaluronan, lubricin, those are all decreased. Now, I can't tell that by looking. I'm like, oh, this is very low. But you can feel the material in your fingers. You can feel the viscosity relative to somebody's healthy knee, and there's definitely a difference, right? So viscosity in those patients can be measured. Usually they'll measure things like that in Dalton's, just like they measure the viscosupplementation injections in Dalton's as well. So where we have a condition that requires lubrication and viscosity, we don't have it, right? So that's a problem. We don't have right now you'd want a lower weight oil trying to start your car in this kind of weather. Or in the summer, you want a higher weight oil. higher viscosity. Right now, we look at synovial fluid, we analyze it, and the viscosity is quite low in these patients with osteoarthritis. So to summarize, we have articular cartilage degeneration, meniscal degeneration, and sometimes frank tears in the meniscus. If I see a very worn medial or lateral compartment, I'm almost certainly going to find a meniscus tear of some kind in that compartment. Now, it doesn't serve really too much of a purpose to MRI these patients. Oh, you have a meniscus tear, because you can do that in everybody, and that really isn't what's generating the pain in those patients. So that's sort of a slippery slope where if you're ordering a lot of MRIs, you're going to find a lot of tears, but are they even symptomatic? Synovial inflammation, and that goes with osteoarthritis. It doesn't have to be your rheumatoid patients at all. Synovial fluid with diminished lubrication, or we should say diminished capacity to lubricate. And then joint failure, although different in its complexity compared to kidney and heart failure, it does exist. Right? The joint fails, it doesn't bend, it doesn't straighten, it doesn't bear weight like it should. It causes a lot of pain, right? It causes changes in the patient's ability to live their lives, just like these other diseases do. So very important, when we're looking at patients, we want to know a little bit about their history. One of the first things we ask patients, not, which knee hurts. Hopefully I know that before they come in the room. But, what activities are causing you pain? Does it hurt all the time? Does it hurt at rest? Or the patient's like, no, I feel good just sitting here, which is good. I'm happy for them. But how much of your life can you do just sitting there, right? So we have to say, okay, what activities make it worse? Well, could be walking up and down stairs, right? We put a lot more force across that patellofemoral joint or that patella going upstairs or going downstairs than we do walking on flat ground. And even between the tibia and the femur, there's quite a bit of force just walking, right? So we're just walking. Somebody might, maybe I weigh about 200 pounds, right? So if I'm walking 3 times my body weight with every step, that's about 600 pounds. That's quite a bit. Now, if you're in great shape and you have no cartilage issues, you're not going to even know it. Right? You're not going to even know it. But suppose you're lacking a little bit of quadricep strength, right? Maybe you have a flexion contracture. And so the quad's always firing when you're trying to walk, and you're missing cartilage in the medial compartment. That's going to be a bigger problem for you than somebody who has a healthy knee. All right. So the history, and I would say, I don't know about history, I'd sort of transplant that word and put physical exam in there. Begins before the patient enters the room. So what I try to do when patients come into the office, especially the first time, is just get a look at them walking. I just want to watch them walk. And I want to know, is the whole problem the knee? Is it the right knee? Is it both knees? Is there a variant in there that some of that component is hip, maybe left hip, right knee? Is it a spine issue? Is there weakness? Are they using is it an antalgic gait, right? So are they limping? Are they using a walker, using a cane? All those things are huge clues for me in terms of what's going on with that patient. Watch their stride length. Is it equal, right? Is that swing phase the same from leg to leg? Is there an alignment issue? Are they varus? They look like a cowboy. Are they knock-kneed? Again, are they using that cane or walker or other things? Is there an AFO on the ankle or foot? That has a lot to do with it too. Is their heel, do they have a valgus heel? Is the heel way out here and they're super flat-footed? Those kind of things. And so all those things play into that patient's history and physical. So I think these are important, right? So where does it hurt? And I always tell patients, put a finger on the worst part. And whether it's a knee exam, a hip exam, shoulder, elbow, doesn't matter. I want them to tell me where it hurts. I want to see a finger go somewhere. Because this is probably a little bit more detailed than this, right? And I start to think other things when they use sort of the whole palm and point to the whole extremity. I start to think maybe it's not elbow, maybe it's something else. Same with the leg. Is there a history of trauma? So not did you get hit by a car a couple of days ago, but any previous surgeries? Did you tear a meniscus playing football? Were you on the volleyball team? You had an ACL reconstruction? Those kind of things are critically important. And then what makes it better or worse? And in that regard, it can be, well, I take Tylenol, I take Motrin, I take ibuprofen, I take meloxicam, or I stopped that activity. I haven't exercised in 6 weeks because of it. So I want to know if there's been changes in their activity level too, because those are very important as well. So the symptoms may wax or wane with recent activity or body stressors like illness. Maybe they're stuck in a hospital for 2 weeks. That's definitely going to degrade somebody. There's no question about that. And you may see that they have exacerbations of their arthritis. Not that they got arthritis, mind you, right? They didn't get it while they were in for pneumonia, but they have a chronic problem, arthritis, with an acute on chronic issue. And that is an exacerbation of that pain. Maybe it's the hip, maybe it's the knee, maybe it's not the hip, maybe it's trochanteric bursitis from sitting in bed, in the hospital. But it's not unusual to see exacerbations during an unrelated admission. We want to do a good physical exam. So again, let them point to where it hurts. Then you put hands on that knee and find out, okay, it clearly is medial pain. It's worse if I palpate it, right? Because they're not weight bearing necessarily when you're doing this. Do I notice a valgus or a varus deformity, right? Varus deformities are usually accompanied by medial joint space narrowing, and valgus deformities are usually accompanied by lateral joint space narrowing. Do they have an effusion, right? So an effusion is different than swelling, right? Swelling is a soft tissue issue, right? Edema, let's call it edema. And an effusion is intra-articular fluid. Sometimes that fluid is synovial. Sometimes it's infectious, right? If we have an infection. And sometimes it's blood if we have a trauma, right? Do we have a fracture inside the knee? And if we have a knee that swells up in about a half hour, probably isn't synovial fluid. It takes a little longer to make that kind of volume. But you can bleed into the knee, no problem. Any of volume you want almost in a half hour, 45 minutes. So just those questions there will help you sort of guide you in a direction of, okay, this is acute, this is chronic. There's an effusion. Should I be concerned with what I'm seeing here now? And then are they able to walk on it, right? So if I have a red knee, the patient looks like they're sick and they can't range the knee actively and they won't walk on it, then I'm starting to think about infection, right? That's infectious. Now, if they have a swollen knee, I fell down the stairs, took about an hour or two to swell up, then I'm worried about maybe something like an ACL or a plateau fracture, or even a patella fracture. Patella's going to bleed like anything else. Just some tests here. We're not going to demonstrate them, but if we're doing the McMurray's test, we're looking at meniscal pathology, right? If we're doing a Lockman's test, and we can do Lockman's with an anterior drawer too, then we're thinking about ACL injuries, right? And sometimes you can accidentally find a PCL injury while you're doing these exams as well, depending on what you're looking for. Flexion contractures, and I think in advanced disease, these are very common. Matter of fact, it's the uncommon patient that doesn't have a flexion contracture with advanced osteoarthritis of the knee. And you're like, well, it gets pretty straight. Yeah, pretty straight is still not all the way straight, right? So if I'm looking at a knee and it looks like it's 5 or 10 or 15 degrees of flexion, and I'm holding it by the heel, especially under general anesthesia, and the knee doesn't straighten, then it's not the patient doing that. There's truly something going on there. Sometimes it's muscles, but they're under anesthesia. So it's probably capsular. It's probably some sort of bone block because of osteophytes to full extension. We mentioned osteophytes there. Crepitus, you sort of feel that Rice Krispies as they're bending and straightening the knee. Sometimes it's over the anterior knee, patellofemoral joint. Sometimes it's medial or lateral. Sometimes it's debris. Could be a meniscal. Right, and that's it. There's some really bad X-rays, right? So that you've just given up on the lateral side knee and decided not to walk on it. You're just going to walk on the medial side. So that's a terrible knee. This is not necessarily the lateral of that knee, and that's not necessarily the sunrise of the knee either. But those are really 3 good X-rays that you can get. Now, added an X-ray to that first bullet, the Rosenberg view, and I would tell you, if you order 3 views or 4 with the Rosenberg, and if there's no contraindication to weight bearing, I'd always order them weight bearing. Then you've done it. You've ordered the perfect set of X-rays for the knee. And if somebody says, well, you should order this, you should order that, don't worry about it. You did a great job just ordering those. You did a great job. So this is an AP, terrible AP, but it's an AP, a lateral, and that's your sunrise, your merchant view, right? So you're looking at the patellofemoral groove, and the patella is sitting right in it. And then there's not a Rosenberg up there, but essentially the Rosenberg view adds some flexion to the knees. It's usually bilateral, and the direction of the picture is a PA, so from posterior to anterior. And what happens is, not that you would need it side, this person has arthritis, but you would look and say, well, there's joint space narrowing, but there's a lot of pain for some joint space narrowing. I really am not seeing a lot in this x-ray. So we do the bent knee view or the Rosenberg view, and all of a sudden there's considerable narrowing on that medial or lateral side. And I think that helps explain maybe the patient's symptoms a little bit better. Or, you're on the verge of deciding, well, is this an injection or is this an arthroplasty, or knee replacement? And we're going to get to Rosenberg because that typically will give you a little clearer picture of the amount of joint space narrowing and amount of degenerative changes that patient truly has. And so that's something. But if you get those three, if you add the Rosenberg, you have done better than 99% of everybody who orders x-rays. And I always encourage you to look at them too. Look at them. You're certainly qualified to look at them. Don't ever think that you're not. I look at our x-rays, every day just about, and then I look at the reports, and they're not that good. They're not that good. So always look at your x-rays. Sometimes they're completely wrong, meaning I'm the patient, I have knee pain, and we're looking at Dr. Spelliscy's report with my name on it. So that happens too. So always sort of look at those reports. Just make sure it is, in fact, the patient you thought it was. We get reads back on 70-year-olds with advanced lumbar spinal stenosis, and because it was the wrong patient, right? It was a lumbar film, right? But not everybody's film is the same. Some of us are old, some of us are younger. And so we're going to have different. So you always want to make sure that the actual report is the patient that you thought it was. And on a regular basis, it's not. So if we look at these, pardon me. These x-rays here, same knee, one's weight bearing and one is not. You can see that lateral compartment looks pretty good. You're like, why are you having so much pain? I don't get it. And then you put the patient in a weight bearing position, you have them stand on it. You can see that their joint space completely disappears when you do that. So that gives you a little better hint of why they're having so much pain, why the ibuprofen isn't helping, why you may consider at this point at least an injection and maybe more than that. Here's a Rosenberg series right here. And essentially you can see volunteer A, extension, Rosenberg, not much of a change here immediately. Volunteer B, extension, then the Rosenberg, both weight bearing, both the same patient, and now you have sort of obliteration of that joint space. So sometimes that Rosenberg can make a huge difference. Now, if you have cartilage, it doesn't make any difference. But if you don't, it could make quite a bit of difference. What about MRI? Sometimes that's a bag of worms. Getting an MRI, like I said before, if you just want to find meniscal tears, you will find them in this population of patients. They all have them. The question is it clinically significant? There are times when it is. You can have a 65-year-old patient that has a clinically relevant meniscus tear. They may have very little osteoarthritis. It may be a relatively acute finding. They have an effusion. They localize to the medial compartment. They click and pop, right? When you do McMurray's, or if you do any one of the other tests for that, may be positive. Then the clinical picture starts to point towards medial meniscus tear as the problem and not osteoarthritis. But if you have maybe that patient way back who was just walking on their medial side and you find that they have a medial meniscus tear, I would almost venture to say that's irrelevant given the osteoarthritic changes of the knee. So this can be a double-edged sword here when you order these MRIs. Now, certainly this is a tear. This is a sagittal view of the knee. We're looking at it appears to be the medial compartment here, at least on this one. This one's tough to tell because that's pretty flat. But if you look at the meniscus, that should look like a black triangle, okay, or a black wedge. you can see there's some whiteness going into that wedge there, and it's exiting on one of the articular sides. In this case, the tibial articular side. So that would be a grade 3 change. That's where a radiologist would call that. And then some will go a step further and call it a tear, but that certainly is a tear. Same here as well. You sort of see that it's not homogeneous, it's heterogeneous in terms of color. That would be a grade 3 change as well. But like I said, you can get into a little bit of trouble, looking for a meniscus tear in some of these patients because you'll find it. The question is, what do you do with it now that you found it? All right. And oops, pardon me. And I think that that's pretty accurate. When you look at this population of patients, especially with medial disease, you're going to find posterior medial tears. We go in to do knee replacement. I can see the anterior medial aspect of the meniscus. I grab a hold of it, cut it out because I need it out of the way to do some other things. And I'm like, well, the posterior, where's the posterior half of it? And I don't get to that until I've removed enough bone where it's uncaught from the back of the knee. So it's sort of extruded and sitting in the back, caught in the back of the knee. So they all have tears. I rarely say, oh, it's a shame I'm cutting this out. That never is the case. And again, you want to sort of correlate your physical exam findings, the patient's complaints, and that MRI when you do have a discussion about medial meniscus tears in that, so let's say over 45 population. All right, and okay, so here is an example of that. So over 60% of patients over age 65 have some sort of asymptomatic degenerative meniscus tear. So just something to watch for. It's very common, very common. And shaving it out is not going to be, and certainly you're not going to repair it, but shaving it out is not going to be the answer to their pain dilemma. Usually it is articular cartilage. Right now, there are some things besides meniscus tears that we can find on MRI, and this slide would lead into another lecture that we have. But essentially, these bone bruises, right, or bone marrow lesions, you can see here. You got a T2 image, right? So dark bone, except for here, right? That's bone marrow. That's bone edema, and those things can be painful as well. And there are ways to treat those. Some people believe in that, some people don't. But essentially, it could be a very good way to explain away pain in light of not having a meniscus tear and still having some joint space left, right? Now, what do you do with those? How do you treat them? In many cases, I'll treat them like a fracture. So some sort of limitation in weight bearing for about 6 weeks, put them on a walker, and then I'll say, listen, you can graduate from this walker when you're asymptomatic. And most of the time, it takes care of the problem. Rarely do I have to go back and do anything with that, or very rarely a knee replacement, something like that. But those lesions are out there. All right. This was from, again, going down that road of bone marrow lesions. Relatively normal looking x-ray, right? Very symptomatic medial pain. You go down here, you see that bone marrow edema here and here, likely the cause of the pain in that particular patient. A lot of things in the medial side though, right? Medial compartment, medial meniscus, medial collateral ligament. There's a lot of things that can hurt on that side. That's why your history is so important. So in terms of osteoarthritis, most of us are interested in what we're going to do on a conservative basis. Even myself, a majority of patients that we see for osteoarthritis aren't going to get knee replacements that day, right? So we're going to do something easy. And a lot of times the patients have already started doing this at home with some success, right? And what they're looking for, though, is for you to reinforce that they're doing the right thing. Can I put ice or heat? I really never tell anybody to put heat on anything. Unless they're going to, start maybe their shoulder exercises for the day, and I want that joint heated up a little bit. I think that's perfectly fine. Otherwise, though, if they're having pain, if it's at the end of the day, if they have some swelling, I think ice is very helpful. It's our option that doesn't cause GI upset as an anti-inflammatory. And again, may allow them to continue their exercise programs without anything more, like osteoarthritis medications, for example, injections. If they need to use an aid like a cane, we're going to use it in the opposite side. I prefer, canes I think are difficult to use if you're at that point, and I find that more of a fashion statement than anything else. I like walkers more than that. I think you can walk further with a walker. I think it's more stable. Now we have 2 hands and 2 feet touching something as the patient's ambulating, especially in this kind of weather. So I'm a big fan of walkers. Weight loss, yeah, you know, it can help in terms of patients that are having some knee pain and trying to reduce that knee pain. Is the arthritis going to go away? No, we already said it's degenerative. It's going to progress. But in that patient that maybe is on the cusp of saying, well, I really don't want to start, meloxicam every day for a month. Then the weight loss is an answer. The medications, Dr. Millerano gave a terrific lecture on the medications that are available. They're effective. And I'll let him comment on who gets it. But definitely, if we know that each pound lost results in a 4-fold reduction in the load on that knee, that's you don't have to lose a lot of weight, right? You lose 5 pounds, that's 20 pounds on the joint. Physical therapy, and we'll look at a list of things that the Academy recommends, physical therapy being one of them. It's strongly recommended, and low impact exercises as part of a continuing effort by that patient to stay in shape. But physical therapy, I rarely have a patient who doesn't feel better after physical therapy, especially for knee or hip arthritis. I think it always works in those patients. I think strengthening those muscles around that particular joint are very helpful. And I think it probably helps balance. It probably decreases fall risk in a lot of those patients. So I never think it's a waste of time, prehab. So even if they're going to have surgery, let's get that joint, let's get that leg, let's get that person in the best possible shape before their surgery. Some docs will say, I don't care if they do low impact or high impact. Yeah, because they don't care what happens to your knee. They're going to replace it. But I think that if you stick to lower impact stuff, I think you're going to be happier. Quadriceps, hamstrings, right? I don't know that hamstring stretches prevent flexion contractures, but they may help with it too, especially if you're on that very beginning part of the scale where maybe it's 5 degrees. Can you get full extension? And a lot of those patients, I think you can. Start with a supervised program. Somebody like me needs coaching. They need to be told, hey, you need to do this. Otherwise, I won't do it. I can tell you right now. So, and then they graduate to a program. And I always tell them too. So part of your assignment, besides doing the exercises, is to develop a home program with your therapist, because you're not going to go to therapy forever, right? And when you do graduate to a home program and you can continue something at home, you're going to have a longer improvement, longer lasting improvement, and you're going to keep yourself out of the operating room as long as possible. But if you don't continue it, I would say 6 months is optimistic. 6 weeks after they stop exercising, they're going to be in the same place they were before. But some of them, if they know this is a tool they can use to stay out of the operating room, a lot of them are very good at doing it. Visco supplementation. Anybody do this in our office? Any visco injections or anything like that? Okay. And, if you look strictly at the guidelines by the American Academy of Orthopedics, they don't necessarily recommend this, although a lot of their members are doing it. So the question is, does it help? The idea is that you give the medication, it helps with lubrication and cushioning. Okay. And I think that it does, but it's a very temporary measure. So you may improve viscosity in those patients' knees, but that's synovial fluid viscosity is going to come back down again because that's the nature of their arthritis. Usually we'll use it at 6-month intervals in patients who agree to have it done. We have some patients that we've done for years effectively, and they've not had any replacement or anything like that. So very safe though. I mean, you literally could eat this stuff. It's perfectly safe. Acetaminophen, right? So up to 4 grams a day. I'm sure that many, if not all of you, are currently using that in some of your patients. In terms of inflammation, it's probably not as helpful as the NSAIDs, but probably a lot safer. Tramadol, as we start to try to stay away from the addiction of some of these narcotics, tramadol can be helpful. I don't use a lot of tramadol. I don't use a lot of narcotics either, unless they're post-op patients. So if we look at this very quickly, strengthening exercises, NSAIDs, total knee, strongly recommended. Weight loss, moderately. Now, these are strongly recommended against, right? So these are all the things, arthroscopy for the sake of arthroscopy, bracing, and the braces could be helpful. I often have a patient who wants to work 1 or 2 more years, can't take off. It's their own business. They're like, what can I do? And, they have a varus knee or a valgus knee, and we can use an unloader brace, and they can be effective in the right patient with the right size leg. And so we'll try that. Typically, though, if it's a Medicare patient, with DME, it's not covered. It's going to be $800, $1,000 out of pocket. And for some patients, it's not a big deal. For other patients, it's quite a deal. That's a lot of money. So what other treatment options exist? Once we get through prescription medications, physical therapy, and injections, we're not left with a whole lot. Surgery is one of those things we can try. There's different types of surgery, but let's look at NSAIDs, right? So great drugs, but you even better than I know about the downside of these medications, right? Or GI wouldn't even have a practice if we didn't prescribe these medications. So we got to worry about these patients above 60 that have other comorbid conditions, right? Cardiac conditions, pre-existing GI, peptic ulcer disease, GI bleeds. That's the patient probably scares me away from any kind of NSAID. Oh yeah, I had a GI bleed before. Pretty much you're not getting it then. And then even if they're on a medication, a lot of them will be on PPIs when you prescribe the NSAID. And I try to keep them on it as short as time as possible. I don't want to write a prescription, 11 refills, and then say goodbye, because something's going to happen to that patient, whether it's their kidneys, whether it's their GI tract, something is going to happen. And then so many people are on anticoagulants, right? Aspirin's an anticoagulant. And then people are on the injectable anticoagulants, because they've had a stent put in, or they have peripheral vascular surgery. Everybody, I feel like I should be on it because everybody else is on it. And then I don't see as much like Coumadin and things like that anymore. The other medications are so easy to take. You don't have to draw labs on them. So it's hard to argue against those other medications. But it's this thing here, right? Orthopedic surgeons never want to see those 3 words. Black box warning. That sounds terrible, right? That sounds like a medical condition, and we don't know any of that stuff anymore. So we don't want to make any problems for that patient medically, because we know we can't treat them. So now I know there's another orthopedic surgeon here. He may or may not agree with what I'm saying in terms of medical conditions, but we try not to create any new ones. I think there's plenty of them out there. We don't want to be the cause of that. Different types of NSAIDs, we know that, right? Our COX-2 inhibitors. Same warnings, though. Same warnings. They're just your GI tract thanks you, but your heart and kidneys won't necessarily thank you. So COX-2 inhibitors have been out forever. I'm sure everybody's familiar with them. Some have gone by the wayside since they first came out. Bracing, again, can be helpful. My dad, before he had his knee replacement, did use a brace with some success, so they do help. Just very expensive. Orthotics, that's my price range, $8 to $22. So, you can put those in certain patients' shoes, and they may help. It depends. Hyaluronic acid, we talked about that. If it's going to help, just like if the steroid's going to help, these tend to help a little bit longer, and then later in that sort of treatment phase. So that 0 to 4 weeks, it's usually the steroids better. 4 to 8 weeks, equal efficacy or non-inferior. And then greater than 8, it's the hyaluronic acid. And I'll tell you, if you do injections, does anybody do injections here? And what's sort of your gestalt for deciding what you're going to do? Any thoughts on that, students, interns? If you're going to pick a medication, right? So I don't just say, well, this one pays more, so I'm going to do this one. What I try to do is say, is there an inflammatory process that I'm trying to treat right now? Do I have an effusion that I'm dealing with, right? Is the knee have 40, 50, 60 cc's of fluid in there? Because if it does, I feel like I'm going to do better with a steroid. I feel like I'm going to do better with a steroid. I'm going to give them a little longer relief, maybe prevent a recurrence or as quick a recurrence with that medication, as opposed to the hyaluronic acid, which is not really that helpful. Now, what about if I do this in phases where I have an effusion, I do the steroid of some kind, The effusion gets better. I see them back maybe 3 months later. The effusion's gone, but the knee pain's still there. Maybe that's the time that I switch over to a hyaluronic acid preparation and not a steroid again. Usually when we give steroid injections, we'll give them in combination with a local anesthetic like lidocaine or bupivacaine or both. Okay, sort of like we said here, in combination with lidocaine. Usually I use 0.25% bupivacaine. Bupivacaine is a bit chondrotoxic, so if I don't have to use anything higher than 0.25%, that's helpful. I try to never give them, closer than 3 months apart. This is a particularly different one. This is triamcinolone, but it's an extended relief molecule, and meaning normally we give injections and they're metabolized pretty quickly out of the joint, days, not weeks or months. This one in particular, Zilretta, I don't know if anybody's familiar with that. It's been out since about 2019. It's triamcinolone. It's 32 milligrams as opposed to the 40 we typically give. Give a dose, and it's supposed to maintain residency within the knee for 12 to 14 weeks, which I think is helpful. And I think this does a better job in patients that are chronically effused. Same injection style as you would give a regular injection, nothing different there. This PLGA is sort of the polymer that sort of, as it dissolves, gives off or eludes that medication in the knee. So like an extended relief injection almost. And here they're just looking at the amount of drug that's quantifiable in the knee through week 12. So it still can be found in the knee, which is sort of a big deal. Plasma levels, right? And then something I think that's just as important, patients are always worried, especially diabetic patients, where you give them a steroid, whether it's an injectable, whether it's intramuscular, intraarticular, whether it's oral, right? What are my blood sugars going to do? And we all know the answer to that. They're going to go up, right? How high, I don't know. It depends on how well controlled or uncontrolled they are. But if you look here, you can see that, so the purple is the extended release, and glucose is associated with that. And then the black triangles or inverted triangles are just a typical triamcinolone injection. And so you can see it at 0 hour, the day of the injection, quite a rise in blood sugars, up to 250, 260 or a little bit higher. And here you see that the blood sugars across some normal, which I don't think 180 is, are really not rising above that too far. So you get a release of that 32 milligrams over a period of time instead of a bolus dose that you would get with the 40 milligram injection. And so that really is helpful for your diabetic patients. We talked a little bit about arthroscopy, and these are the things we might do during an arthroscopy: synovectomy, plica removal, which has nothing to do with arthritis, loose bodies if they're in there, chondroplasty, and I'll show you what I'm talking about there, and resection of a torn or damaged meniscus. Again, none of those things really play to the fact that the patient has arthritis and are not going to change the picture clinically, right? So if we see this little bit of cartilage here, right, sort of a grade 2 change, we'll call it, and I did a chondroplasty, I'd simply take the shaver and give that a haircut. That's a chondroplasty. This first slide shows really a grade 0, right? That's normal. I wish my knee looked like that, or I wish everybody's knee looked like that. It's perfect. You can sort of see the rim of the meniscus in the background. This is an arthroscopic probe. This is the tibia. This is the femur, right? This is femur. Could be patella. I can't tell. I don't have any reference. But that could be patella. And then here we see a grade 4, right? So we have cartilage missing. We're actually looking at that subchondral bone. So we have exposed bone in that case. That's a tough one to take care of. Now, suppose the knee was perfect except for that, right? Now there are ways to manage that. We could transplant cells there, right? We could burr that whole piece of the femur off, take a cadaveric femur of the same shape that we sized via CT and fasten that to that same location. So there are things you can do when it's isolated like that. But if that is sort of the story of the knee and the lateral compartment looks just as bad, and patellofemoral compartment looks just as bad, you have osteophyte formation, you have instability, then that's not the patient for that kind of stuff. But in a younger patient with that lesion, that's not a deal breaker. And then again, looking at arthroscopic debridement, this is a New England Journal study. And essentially, whether they did the surgery, whether they did lavage, just run fluid through it, or just made 2 holes in the patient's skin, which I'm not sure how that got by IRB, they had the same reported scores. So it didn't matter, right? It didn't matter in those patients. So we try to avoid at all cost arthroscopy if we're not completely convinced it's meniscus. And again, who's going to be successful? Less than 45, good alignment, mild or no arthritis with a single tear, right? Essentially, your younger patients with meniscal tears. Right. So if we do total meniscectomies, which we don't do anymore most of the time, that was the 70s. Before arthroscopy, they do an arthrotomy, open the knee, meniscus is torn. It's like you get a little bit of mud on your car tire and you replace the tire. You're just like, what did I just do? So that's what was going on in the 70s. And so for the 80s, 90s, and early 2000s, everybody needed knee replacement. So because of that kind of surgery. And sometimes it is isolated. It's unicompartmental disease. And we have unicompartmental arthroplasties where we just replace one compartment. That compartment could be the medial side, could be the lateral side, could be just a patellofemoral joint. Right, there's one right there. Oops, pardon me. That's looks like an Oxford knee. That gives you an idea. Just one side, just the medial side's been replaced here. Bone-on-bone arthritis, and as a generous resection. So, but good survivorship, actually better than this. And now we're allowed to use, in that particular knee, a press fit, so a non-cemented, which may even do better than this in terms of 10 and 15 years survival. Some of the jigs and guides for the uni. Again, that's the Oxford. Total knee arthroplasty, still a gold standard for osteoarthritis, especially end-stage osteoarthritis. And there are just hundreds of thousands of these each year. Patients are like, do I need a card to get through metal detector? I'm like, no, because probably everybody else in line has had a knee replacement too. So you don't have to worry about it. But very, very prevalent surgery. But with prevalent surgery, right, comes the revision of all those surgeries, right? They get loose. The patients are outliving the prosthesis. Or worse yet, on a day like this, they fall in the parking lot and fracture around. Things we never really thought of 20 or 30 years ago, just because the numbers weren't there. Well, the numbers are certainly there. Now we see more and more of those patients in the emergency departments too. And I think these goals of knee replacement are rather obvious. We want to get rid of pain, restore function. We want to restore alignment. That's usually a byproduct of the surgery. Achieve some level of stability for that patient. And then something that's durable, something that's not going to, be disrupted in about 6 months. We want 12, 15, 20 years of lifespan for these procedures, because the other thing, it's sort of weird though. You do it at 65 or 70, you get 20 years, they're 90 and it's loose, right? Now you're operating on a patient who is not the same patient they were 20 or 25 years ago. So that's its own sort of dilemma in my mind too. What do you do and how much do you do in that case? All right, there are references in there. A couple of questions, and we can go through the questions, just yell out the answer. Right, which of the following non-operative treatments for osteoarthritis has the best evidence to support its use, right? We had that big chart. So is it supervised home exercise, hyaluronic acid, heel wedges, acetaminophen, or glucosamine? One, terrific. All right, my patient is a 62-year-old female. She undergoes an uncomplicated total knee replacement. Her range of motion is 0 to 135 degrees. Which of the following is true regarding the immediate postoperative use of continuous, don't worry about this, we didn't even mention it. So CPM machines, continuous passive motion machines, we don't use them, right? There's been no evidence to suggest that added cost has improved outcomes. What are risk factors for developing osteoarthritis of the knee? Which one of these is not a risk factor? So trauma, metabolic syndrome, female gender, increased age, participating in physical fitness. Very good. All the following are common complaints associated with knee osteoarthritis, except knee pain at night, knee pain while climbing stairs, knee stiffness, instability, numbness in the ankle and foot. Except, which one's not associated with knee arthritis? Any ideas? There's no grades. You could just yell it out. Which one? So if my knee hurts, do you think ankle or foot numbness is part of that? Probably not. Which radiographs are most commonly used to identify the degree of degenerative changes in the knee? So MRI, so right off the bat, that sounds like not a radiograph. Knee CT doesn't sound like a radiograph. Ultrasound doesn't sound like a radiograph. Knees, images of the patient lying down or non-weight bearing, or x-rays, AP, Lau, Rosenberg, and Sunrise of the knee, right? That sounds pretty good. All right. Any questions, any clinical questions, any difficult patients that you might have, you just want to ask a question of, you're in between treatments for osteoarthritis of the hip or knee or shoulder, whatever the case may be, I'm happy to answer those.